Hi, welcome to the lecture on obstetrics and neonatal care. This is a very important part of what you may be called to deal with as an EMT. After you complete this chapter and related coursework, you will understand the anatomy as well as the physiology of the female reproductive system as it relates to pregnancy. You will be able to assess and provide emergency treatment for childbirth, including stages of labor, normal delivery, complications of pregnancy, as well as neonatal evaluations and resuscitation. Regarding the National EMS Education Standard Competencies for Special Patient Populations, the EMT will apply fundamental knowledge of growth and development as well as aging and assessment findings to provide basic emergency care and transport for a patient with special needs. Specific to obstetrics, you will be able to recognize and manage normal deliveries, vaginal bleeding in the pregnant patient, anatomy and physiology of normal pregnancy, and pathophysiology of complications of pregnancy. You will also be able to assess a pregnant patient and manage normal deliveries and abnormal deliveries, including nuchal cord, prolapse cord, and breech. You'll also be able to manage third trimester bleeding, like placenta previa and abrupto placentae, and spontaneous abortion or miscarriage, ectopic pregnancies, and eclampsia and preeclampsia. Specific to neonatal care, you will be able to assess and manage newborns and perform neonatal resuscitation. Specific to trauma, as it applies to the special patient populations, you will apply fundamental knowledge to provide basic emergency care and transport based on your assessment findings for a patient who has been acutely injured. The special considerations of trauma specific to this chapter, you will recognize and manage trauma in the pregnant patient. You will also be able to identify and understand the pathophysiology, assessment, and management of trauma in the pregnant patient. Most infants in the United States are delivered in a hospital with doctors and nurses in attendance to care for the mother and the newborn. Occasionally, the birth process moves faster than the mother expects, and you must then decide whether to stay on the scene and deliver the infant or transport the patient to the hospital. We've already talked about this a little bit, but this will be in less detail than the last chapter. The female reproductive system includes the ovaries, fallopian tubes, uterus, cervix, vagina, and breasts. The ovaries are two glands, one on each side of the uterus, that are similar in function to the male testes. Each ovary contains thousands of follicles, and each follicle contains an egg. Females are born with all the eggs they will release in their lifetime. During each menstrual cycle, there will be only one follicle that is successful at maturing and is able to release the egg. Ovulation occurs approximately 2 weeks prior to the beginning of the menstrual period. If fertilized, the egg implants in the endometrium, or the lining on the inside of the uterus. If the egg is not fertilized within 36 to 48 hours after its release, the lining is shed as menstrual flow. Generally, that occurs around the 28th day of the menstrual cycle. The fallopian tubes extend out laterally from the uterus, with one tube associated with each ovary. Fertilization, where the sperm meets the egg, usually occurs when the egg is inside of the fallopian tube. The fertilized egg then continues to the uterus, where it continues to develop into an embryo and implants inside the wall of the uterus. The uterus, or womb, is a muscular organ, and it is here that the fetus grows for approximately 9 months or 40 weeks. And in this picture, it clearly shows a picture of an intrauterine pregnancy. The uterus is responsible for contractions during labor and ultimately helps to push the infant through the birth canal. The birth canal is made up of the vagina and the lower third or neck of the uterus, which is called the cervix. During pregnancy, the cervix contains a mucus plug that seals the uterine opening, preventing contamination. And when the cervix begins to dilate, this plug is discharged into the vagina as pink-tinged mucus, or what we call bloody show. This small amount of blood appears at the beginning of labor and may signal the first stage. The vagina is the outermost cavity of the female reproductive system and forms the lower part of the birth canal. It is about 8 to 12 centimeters in length, and it begins at the cervix and ends at the external opening of the body. The vagina completes the passageway from the uterus to the outside world for the infant to travel. And the perineum is the area of skin located between the vagina and the anus. The breasts produce milk that is carried through small ducts to the nipple, and this provides nourishment to the infant once it's born. Signs of pregnancy in the breast include increased size and tenderness. The placenta is a disc-shaped structure. It attaches to the inner lining of the wall of the uterus and is connected to the fetus by the umbilical cord, and you can see this in the picture on your left. The placental barrier consists of 2 layers of cells, keeping the circulation of the woman and fetus separate, but allowing substances to pass between the two. Anything that is ingested by a pregnant woman also affects the fetus, and this includes nutrients, oxygen, waste products, carbon dioxide, many toxins, and most medications. After delivery, the placenta, or commonly called the afterbirth, separates from the uterus and is delivered. The umbilical cord is the lifeline of the fetus, and it connects the woman and fetus through the placenta. The umbilical vein carries oxygenated blood from the woman to the heart of the fetus, and the umbilical arteries carry deoxygenated blood from the heart of the fetus to the woman. The fetus develops inside a fluid-filled bag-like membrane called the amniotic sac, or more commonly referred to as the bag of waters. The sac contains between 500 to 1,000 milliliters of amniotic fluid, which helps insulate and protect the floating fetus. It is released in a gush when the sac ruptures, usually at the beginning of labor. During pregnancy, many normal changes occur in the body that are not all directly related to the reproductive system. The primary systems involved when these changes occur are the respiratory, cardiovascular, and musculoskeletal systems. In the reproductive system, hormone levels increase to support fetal development and prepare the body for childbirth. This puts patients at an increased risk for complications from trauma, bleeding, and some medical conditions. As the fetus develops and grows, the uterus also grows, stretching to accommodate a full-term infant. As the size of the uterus increases, so does the amount of fluid it must hold. The uterus is displaced out of its normally protected position, and this increases the chance of a direct fetal injury. The size of the uterus will also have a direct effect on the respiratory and cardiovascular systems because the organs are shifted from their normal position. Rapid uterine growth occurs in the second trimester of pregnancy. As the uterus grows, it pushes up on the diaphragm and displaces it from its normal position. As pregnancy continues, respiratory capacity changes with increased respiratory rates and decreased minute volumes. Overall blood volume gradually increases throughout the pregnancy to meet the increased needs of the fetus and to allow for adequate perfusion of the uterus. To prepare for the blood loss that will occur during birth is also part of this process. Blood volume may eventually increase as much as 50% by the end of pregnancy. The number of red blood cells also increases, and the patient is able to clot faster to protect herself from excessive bleeding during delivery. By the end of the pregnancy, the patient's heart rate increases up to 20% to accommodate the increase in blood volume, and that significantly increases cardiac output. In the third trimester, there is an increased risk of vomiting and potential aspiration following trauma because of the changes that occur in the GI tract. These changes include gastrointestinal motility and the displacement of the stomach upward, and this significantly increases the chance that a pregnant trauma patient will vomit and aspirate if you are unable to clear her airway. Changes in the cardiovascular system and the increased demands of the fetus significantly increase the workload of the heart. Remember, not all women are healthy when their pregnancy began, and cardiac compromise can be a life-threatening possibility. Weight gain is expected in pregnant patients. The increase in body weight will eventually challenge the heart and musculoskeletal system. The increased hormones affect the musculoskeletal system by making the joints more loose or less stable, and in the third trimester, changes in the body's center of gravity increase the risk of slips and falls. There are 3 stages of labor: dilation of the cervix, which is stage 1, delivery of the infant, which is stage 2, and delivery of the placenta, which is stage 3. The first stage begins with the onset of contractions as the fetus enters the birth canal and ends when the cervix is fully dilated. The first stage is usually the longest, lasting an average of 16 hours for the first pregnancy. The onset of labor starts with contractions of the uterus. Other signs of the beginning of labor are the bloody show and the rupture of the amniotic sac. The frequency and intensity of contractions in true labor increase with time. The uterine contractions become more regular and last about 30 to 60 seconds each. Labor is generally longer in a prima gravida than in a multigravida. Prima gravida is first pregnancy. Multigravida is many pregnancies, or more than one. Table 31-1 discusses how to tell when true labor is occurring. A woman may experience preterm or false labor or Braxton Hicks contractions. You should provide transport for the patient, and if it is true labor, you may need to prepare for delivery. So as I said, this table gives a great comparison of false or Braxton Hicks contractions versus true labor, and it's a great study guide. Please use it. Some women experience a premature rupture of the membranes in which the amniotic sac ruptures too early and the fetus is not developed or ready to be born. The patient may or may not go into labor. You will need to provide supportive care and transport this patient to the hospital. Toward the end of the 3rd trimester, the head of the fetus normally descends into the woman's pelvis as the fetus positions for delivery. This movement down into the pelvis and the sensation that may accompany the descent is called lightning. The 2nd stage of labor begins when the fetus begins to encounter the birth canal and ends when the infant is born, called spontaneous birth. During this stage, you will have to make the decision about helping the mother to deliver at the scene or providing transport to the hospital. Uterine contractions are usually closer together and last longer, and under no circumstances should you allow the mother to sit on the toilet. The perineum will begin to bulge significantly, and the top of the infant's head should begin to appear at the vaginal opening, and this is called crowning. The 3rd stage of labor begins with the birth of the infant and ends with the delivery of the placenta. During this stage, the placenta must completely separate from the uterine wall, and you should always follow standard precautions to protect yourself, the infant, and the mother from exposure to blood and body fluids. Complications of pregnancy. Most pregnant women are healthy, but some may be ill when they conceive or become ill during pregnancy. You may safely use oxygen to treat any heart or lung disease in a pregnant patient without causing harm to the fetus. One complication that occurs most commonly in patients who are pregnant for the first time is preeclampsia, commonly referred to as pregnancy-induced hypertension. This condition can develop after the 30th week of gestation, and it is characterized by the following signs and symptoms: headaches, seeing of spots, swelling in the hands and feet, anxiety, and elevated blood pressure. Another condition, called eclampsia, is characterized by seizures that occur as a result of the hypertension. In order to treat a patient who has eclampsia, the patient should lie on their side, preferably their left, maintain an airway, provide supplemental oxygen, suction the airway if vomiting occurs, provide rapid transport, and call for an ALS intercept if available. By transporting the patient on their left side, this can also prevent a phenomenon called supine hypotensive syndrome. This occurs when the compression of the descending aorta and the inferior vena cava by the pregnant uterus when the patient lies supine, and this results in hypotension. That's why it's important to roll the patient onto their left side, because that relieves the pressure on both the aorta and the vena cava. Bleeding. Internal bleeding may be the sign of an ectopic pregnancy, a pregnancy that develops outside the uterus, most often in a fallopian tube. This occurs about once in every 300 pregnancies. And here is an example of an ectopic pregnancy where the fetus, the embryo, is developing inside the tube. The leading cause of maternal death in the 1st trimester is internal hemorrhage into the abdomen following the rupture of an ectopic pregnancy. You should consider the possibility of an ectopic pregnancy in women who have missed the menstrual cycle and complain of sudden stabbing and usually unilateral pain in the lower abdomen. Hemorrhage from the vagina that occurs before labor begins may be very serious, and you should call for ALS assistance. In early pregnancy, it may be a sign of a spontaneous abortion or miscarriage. In the later stages of pregnancy, vaginal hemorrhage may indicate a serious condition involving the placenta. In the condition of abrupto placentae, the placenta separates prematurely from the wall of the uterus, most commonly caused by hypertension in the mother and as a result of trauma. In placenta previa, the placenta develops over and covers the cervix. Decreasing the patient's anxiety during these situations will directly impact how she and the fetus may respond during the emergency. This slide shows 2 different pictures. On the right side, you have placenta previa, where the placenta will be the presenting part as it is covering the cervix. On the left side, the photo shows abrupta placentae, where the placenta separates prematurely from the wall of the uterus and it's causing bleeding into the uterine lining. Diabetes. Diabetes develops during pregnancy in many women who have not had diabetes previously. This condition, called gestational diabetes, will resolve after delivery. The treatment is the same as for any other patient with diabetes. A pregnant woman may control her blood glucose level with diet and exercise or may take medication. In some cases, the woman will have to manage her condition with insulin. With a trauma call involving a pregnant patient, you have two patients to consider, the woman and her unborn fetus. Any trauma to the woman has a direct effect on the condition of the fetus. You also must remember that a pregnant woman may be victim of many types of trauma, including assaults, motor vehicle crashes, shootings, and domestic abuse. Pregnant women also have an increased risk of falls compared with non-pregnant women because hormonal changes loosen up the joints in the musculoskeletal system, and the weight of the uterus and displacement of the abdominal organs change the patient's balance. Pregnant women have an increased amount of overall total blood volume and an approximate 20% increase in their heart rate by the third trimester. A pregnant trauma patient may have a significant amount of blood loss before you will see or detect signs of shock. The fetus also may be in trouble well before signs of shock present themselves. Pregnant trauma patients need to have additional concerns considered and unique types of injuries assessed for and managed. The uterus is especially vulnerable to penetrating trauma and blunt trauma. Some data suggest that almost 70% of all penetrating abdominal trauma in pregnant patients results in fetal injury. A trauma injury to a pregnant uterus can be life-threatening to the woman and fetus because the uterus has a rich blood supply. And in most cases, the only chance to save the fetus is to adequately resuscitate the mother. When a pregnant woman is involved in a motor vehicle crash or a similar mechanism of injury, severe hemorrhage may occur from injuries to the pregnant uterus. Trauma is one of the leading causes of abruptoplacenta. You should suspect abruptoplacenta when the MOI is blunt trauma to the abdomen and the patient's signs and symptoms are suggestive of shock. Significant vaginal bleeding is common with severe abdominal pain. You need to quickly assess and transport the patient and support their airway. You should administer high-flow oxygen, place sanitary pads on the vagina, and position the patient on their left side and call for ALS assistance. Not all pregnant women properly position their seat belts when they're in a vehicle. If the pregnant woman is involved in a motor vehicle crash with an improperly positioned seat belt, the seat belt can cause harm to both the mother and the fetus, and you should carefully assess the abdomen and check for seatbelt marks, bruising, and obvious trauma. If a pregnant trauma patient goes into cardiac arrest, your focus is the same as with other patients in cardiac arrest. Remember, the only chance you have to save the infant is to do all you can for the mother. Perform CPR, provide transport to the hospital according to local protocol. You should notify the receiving facility personnel as soon as possible that you are en route with a pregnant trauma patient in cardiac arrest. Your focus is on the assessment and management of the woman. You should suspect shock based on the mechanism of injury. Be prepared for vomiting and anticipate the need to manage the airway to protect the patient from aspiration. Attempt to determine the gestational period to assist you with determining the size of the fetus and position of the uterus. You should follow these guidelines when treating a pregnant trauma patient. Maintain an open airway. Be prepared for and anticipate vomiting. Keep your suction unit readily available. Administer high-flow oxygen. Keep the oxygen saturation level high. Administer high-flow 100% oxygen via a non-rebreather mask. Ensure adequate ventilation. Listen to lung sounds and confirm that bilateral breath sounds are present. If the patient has inadequate ventilation, you may provide or assist ventilations with a bag mask device and 100% oxygen. Assess circulation. Maintain a high index of suspicion for internal bleeding and shock based on the mechanism of injury. Keep the patient warm and make your transport decision. The patient should be transported on her left side. If spinal injury is suspected, tilt the backboard to the left and transport the patient to a trauma center if one is available in your area. The United States is a culturally diverse nation. Women of some cultures may have a value system that will affect their pregnancy, the choice of how they care for themselves during their pregnancy, and how they have planned the childbirth process. Some cultures may not permit a male healthcare provider, especially in the pre-hospital setting, to assess or examine a female patient. You should respect these differences and honor requests from the patients if at all possible. Your responsibility is to the patient and is limited to providing care and transport. A competent, rational adult has the right to refuse all or any part of your assessment and care. Teenage pregnancy. The United States has one of the highest teenage pregnancy rates compared with other developed countries. There is a good chance that during your career you will respond to a pregnant teenager who may or may not be in labor. Adolescents present their own challenges to the EMS community in terms of physical and psychological development even without being pregnant. Pregnant teenagers may not know they are pregnant or may be in denial about it. As you begin to assess all female teenagers, remember pregnancy is a possibility. Respect the teenager's privacy and need for independence, and if possible, perform your assessment and obtain the history away from her parents. Patient assessment. Childbirth is seldom an unexpected event, but there are occasions when childbirth becomes an emergency. Dispatch protocols usually include the dispatcher asking simple questions to determine whether birth is imminent, and contractions may be caused by trauma or medical conditions. Our patient assessment steps include the scene size up, the primary assessment, history taking, the secondary assessment, and reassessment. Your safety is a priority and you need to take standard precautions. Glove and eye protection are a minimum if delivery has already begun or is complete. If the call is going to result in a field delivery, and if time allows, a mask and gown should also be used. Do not be complacent in your safety observations and precautions, and you need to remain calm and professional. Consider the calling for additional or specialized resources. You will encounter pregnant patients who are not in labor, so it is important to determine mechanism of injury or nature of the illness. Do not maintain tunnel vision during a call, and remember that falls and spinal immobilizations must be considered. Form a general impression. The general impression should tell you whether the patient is in active labor or if you have time to assess for imminent delivery and address other possible life threats. Perform a rapid scan of the patient and take a moment to confirm whether the infant will be delivered in the next few minutes or whether you have time to continue to evaluate the situation. When trauma or other medical problems are the presenting complaint, evaluate these first and then assess the impact of these problems on the fetus. Use the AVPU scale to determine the patient's level of consciousness. During an uncomplicated birth, life-threatening conditions with the mother's airway and breathing are usually not an issue. However, a motor vehicle crash, an assault, or any number of medical conditions may cause a life threat to exist and sometimes result in a complicated delivery. Assess the airway and breathing to ensure they are adequate, and if needed, provide airway management and high-flow oxygen. External and internal bleeding are potential life threats to the patient and should be assessed early on. Blood loss after delivery is expected, but significant bleeding is not. You should quickly assess for any potential life-threatening bleeding and begin treatment immediately. Assess for skin color, temperature, and condition, and check the pulse to determine if it is too fast or too slow. If there are signs of shock, control the bleeding, give oxygen, and keep the patient warm. Make your transport decision. If delivery is imminent, you must prepare for delivery at the scene. The ideal place to deliver an infant is in the security of your ambulance or the privacy of the mother's home. The area should be warm and private with plenty of room to move around. If delivery is not imminent, prepare the patient for transport and perform the remainder of the assessment en route to the emergency department. You should administer oxygen, and remember that pregnant women in the last 2 trimesters of pregnancy should be transported lying on their left side when possible. If spinal immobilization is indicated, secure the mother to the backboard and elevate the right side of the board with rolled towels or blankets. Provide rapid transport for pregnant patients who have significant bleeding and pain, are hypertensive, are having a seizure, or who have an altered mental status. Investigate your chief complaint. You will encounter pregnant patients who are not in labor. Your thorough patient assessment will enhance your ability to determine the patient's primary problem. Determining a pregnant patient's chief complaint and beginning asking questions that will help you identify the cause of her complaint and the associated signs and symptoms are paramount. You should obtain a thorough obstetric history, including her expected due date, any complications that she is aware of, if she has been receiving prenatal care, her thorough medical history. Most pregnant patients in the late stages of pregnancy will be able to tell you if they are feeling anything different with the fetus. If your patient is in labor, focus your questions to determine whether delivery is imminent and find out how long the contractions have been occurring and how long they are lasting, whether the patient's water has broken, and whether the patient feels like having a bowel movement. Obtain your sample history. Some pregnant women have a history of medical problems and take prescription medications. Some women who have not experienced medical problems require medications once they become pregnant. Do not focus only on the pregnant history. Get your sample history as well. The pertinent past history should relate specifically to prenatal care, and you should identify any complications she may have had during the pregnancy or potential complications during delivery. Determine her due date, the frequency of her contractions, the history of previous pregnancies and deliveries, and determine whether there is a possibility of twins or whether the mother has taken any drugs or medications. If her water has broken, ask whether the fluid was green. Green fluid is due to meconium or fetal stool. The presence of meconium can indicate newborn distress, and it is possible for the fetus to aspirate meconium during delivery. A complete assessment of the major body system should also be performed with emphasis on the patient's chief complaint. You should assess for fetal movement by asking the patient whether she can feel the baby moving. And for a pregnant patient who is in labor, your physical exam should be focused on contractions and delivery. If at any point you suspect that delivery is imminent, you should check for crowning. If you do not suspect an imminent delivery and the patient has other complaints unrelated to delivery, you should not visually inspect the vaginal area. Obtain vital signs. This should include pulse, respirations, skin color, temperature and condition, and blood pressure. Pay special attention to tachycardia and hypotension or hypertension. It is typical for a woman's blood pressure to drop slightly during the first 2 trimesters of pregnancy, but return to normal during the 3rd trimester. Hypertension, even mildly elevated blood pressure, may indicate more serious problems. Repeat your primary assessment with a focus on the patient's ABCs, vaginal bleeding, especially after delivery. Obtain another set of vital signs and compare with those obtained earlier. Recheck your interventions and treatment to see if they were effective, and remember uterine massage can be used to slow vaginal bleeding after delivery. In most cases, childbirth is a natural process that does not require your assistance. When childbirth is complicated by trauma or other conditions, any interventions you provide for the patient will benefit the fetus. If your assessment determines that delivery is imminent, notify staff at the receiving hospital and provide an update on the status of the mother and newborn after delivery. On the rare occasion that delivery does not occur within 30 minutes or you determine that a complication is occurring that cannot be treated in the field, notify the hospital, provide rapid transport. For a pregnant patient with a complaint unrelated to childbirth, be sure to include the pregnancy status of the patient in your radio report. The hospital staff will want to know the number of weeks gestation, her due date, any known complications of pregnancy, and know that you will have 2 patient care reports to complete, mom and baby. Preparing for delivery. Consider delivering the infant at the scene when delivery can be expected within a few minutes, or a natural disaster, inclement weather, or other environmental factor makes it impossible to reach a hospital. To determine if delivery is imminent, ask the patient the following questions. How long have you been pregnant? When are you due? Is this your first baby? Are you having contractions? If so, how far apart are they and how long do they last? Do you feel as though you will have a bowel movement? Have you had any spotting or bleeding? Has your water broken? Were any of your previous children delivered by C-section? To help you determine potential complications, you should ask the patient these questions. Have you had problems in a previous pregnancy? Do you use drugs, drink alcohol, or take medications? Do you know if there is a chance of a multiple birth, for example, having twins or more than one baby? Does your doctor expect complications? If the patient has delivered before, she may be able to tell you whether she is about to deliver. If the patient says she is about to deliver, you should immediately prepare for delivery. Otherwise, does she have an extremely firm abdomen? Does she say that she has to move her bowels or feel the need to push? If so, the infant's head is probably pressing on the rectum and delivery is about to occur. At this point, you should visually inspect the vagina to check for crowning. Do not touch the vaginal area until you have determined that delivery is imminent. Once labor has begun, there's no way to slow it down or stop it. Never attempt to hold the patient's legs together, and do not let her go to the bathroom. Instead, reassure her that the sensation of needing to move her bowels is normal and that it means she's about to deliver the baby. If your decision is to deliver at the scene, remember that you are only assisting the woman with delivery. Your part is to help, guide, and support the baby as it is born. You want to appear calm and reassuring while protecting the woman's modesty, and recognize when the situation is beyond your level of training. If delivery is imminent, contact medical control for a decision to deliver at the scene or to transport.
To prepare for delivery, use a prepackaged delivery kit of medical supplies or appropriate substitute items which are as clean as possible. Place the mother on her back with knees bent and legs drawn up and apart. The mother is going to feel pressure in the vaginal area as if she has to move her bowels. Do not let her go to the bathroom, and do not hold her legs together. Do not touch the vaginal area except during delivery. If you have a partner, have him or her stay with you during the child.
Your emergency vehicle should always be equipped with a sterile emergency obstetric kit, OB kit, including surgical scissors or scalpel, umbilical cord clamps, umbilical tape, a small rubber bulb syringe, towels, 4x4 gauze sponges and a 2x10 and or 2x10 gauze sponges, sterile gloves, an infant blanket, sanitary napkins, an infant-sized BVM device, goggles, and a plastic bag. When positioning the patient in preparing for delivery, you need to remember these things. The patient's clothing should be pushed up to her waist, and pants and undergarments should be removed. Remember, preserve as much of the patient's modesty as possible. Place the patient on a firm surface that is padded with blankets, folded sheets, or towels, and elevate the hips about 2 to 4 inches with a pillow or blankets. You should support the head, neck, and upper back with pillows and blankets. Communicate with your crew and plan where you will place the newborn after delivery. If the emergency delivery is occurring at home, you should move the patient to a sturdy flat surface or the floor if she will allow it. And track the progression of delivery closely at all times. Preparing the delivery field. Place towels or sheets on the floor around the delivery area to help soak up body fluids and to protect mom and baby. Elevate the patient's hips and support her head and shoulders with folded blankets or pillows. Open the OB kit carefully so that its contents remain sterile. Put on the sterile gloves. Use the sterile sheets and towels from the OB kit to make a sterile delivery field. Place one sheet or towel under the patient's buttocks and unfold it toward her feet. Wrap another sheet behind the patient's back and drape over each thigh. Drape another sheet across the abdomen. Delivery. During the delivery process, your partner should be at the patient's head to comfort, soothe, and reassure the patient during delivery. If the patient will allow it, apply oxygen. It is common for patients to become nauseated during delivery, and some may vomit. If this occurs, have your partner assist her and clear her airway. Continually assess the patient for crowning. Some patients may experience precipitous labor and birth, and you should not allow an abrupt or explosive delivery to occur. Position yourself so that you can see the perineum at all times and time the patient's contractions. Remind the patient to take quick, short breaths during each contraction, but not to strain. Between contractions, encourage the mother to rest and breathe deeply through her mouth. You should follow the steps in Skill Drill 31-1 for infant delivery. Delivering the head. Observe the infant's head as it begins to exit the vagina so you can provide support as it emerges. Place your gloved hand over the emerging bony parts of the head and exert very gentle pressure on it, decreasing the pressure slightly between contractions. Continue supporting the head as it rotates. Some methods of reducing the risk of perineal tearing during labor include applying gentle pressure across the perineum with a sterile gauze pad and applying gentle pressure to the head while gently stretching the perineum. Be prepared for the possibility of the mother having a bowel movement because of the increased pressure on the rectum, and be careful that you do not poke your fingers into the infant's eyes or into the fontanelles. If you see an unruptured amniotic sac, these are the things you need to remember. Usually, it has already broken or ruptured at the beginning of labor or during contractions. If it is not ruptured by this point, it will appear as a fluid-filled sac emerging from the vagina. The sac will suffocate the infant if it is not removed, and you may puncture it with a clamp. Make sure that the puncture site is away from the infant's face and only perform this procedure as the head is crowning. Clear the infant's mouth and nose immediately using the bulb syringe and gauze, and if amniotic fluid is greenish, notify the receiving hospital. As soon as the head is delivered, use one finger to feel whether the umbilical cord is wrapped around the infant's neck. This is commonly called a nuchal cord. A nuchal cord that is wound tightly around the neck could cause the infant to strangle. Usually, you can slip the cord gently over the infant's delivered head. If not, you must immediately cut it. Once you have delivered the infant's head and verified that no nuchal cord is present, you will need to suction the amniotic fluids from the infant's airway before the delivery proceeds. And remember, always suction mouth before nose. You must ask the mother not to push while you are doing this. While supporting the infant's head with one hand, quickly and efficiently suction the fluid from the mouth first and then the nostrils. Make sure the syringe does not touch the back of the mouth, and discard the fluid into a towel, and repeat the procedure suctioning mouth and nostrils 2 or 3 times each until they are clear.
If the amniotic sac is not broken as the baby's head starts to deliver, tear it with your fingers and push it away from the infant's head and mouth. As the infant's head delivers, if the umbilical cord is wrapped around the neck, try to slip it over the baby's shoulder. If you can't, try to reduce pressure on the cord. Never pull on it. When the umbilical cord stops pulsing, tie it in the middle using gauze. There's no need for you to cut the cord. Leave that job for more highly trained personnel.
Once the head has been delivered, it usually rotates to one side or the other. This rotation places the infant in a better position to deliver the rest of the body. The infant's head is by far the largest part of the body, and once it is born, the rest of the infant usually delivers very easily. Support the head and upper body as the shoulders deliver, and do not pull the infant from the birth canal. Grasp the infant's feet as they are born. Support and hold the infant with both of your hands. The infant will be slippery and covered with a white cheesy substance called vernix caseola. Dry off the infant and wrap him or her in a blanket or towel immediately. Place the infant on one side with the head slightly lower than the rest of the body. Wrap the infant so that it is only his face is exposed and making sure that the top of the head is covered. Keep the blanket or towel warm if possible before you use it. Wipe the infant's mouth with the sterile gauze pad and suction the mouth and nose. You can pick up and cradle the infant and keep the infant at the level of the mother's vagina until the umbilical cord is cut. Always keep the infant's head slightly downward to prevent aspiration. Once the infant is born, the umbilical cord is of no further use to the mother or infant. Post-delivery care of the umbilical cord is important because infection is easily transmitted through the cord to the infant. You should clamp and cut the cord, and so you tie the end coming from the infant with a special umbilical tape. Give the wrapped infant to your partner to complete the infant's initial care. You can give the infant to the mother if she is alert and stable. The mother may actually want to begin breastfeeding at this time. Delivery of the placenta. The placenta is attached at the end of the umbilical cord that is coming out of the mother's vagina. Again, your job is to only assist. The placenta delivers itself, usually within a few minutes of the birth, although it may take as long as 30 minutes. Never pull on the end of the umbilical cord. Wrap the entire placenta and cord in a towel and place them in a plastic bag and take them with you to the hospital. After delivery of the placenta and before transport, place a sterile pad or sanitary napkin over the vagina and straighten the mother's legs. You can help slow bleeding by gently massaging the mother's abdomen with a firm circular kneading type motion, and you should be able to feel a firm grapefruit-sized mass in the lower abdomen, and this is called the fundus. Record the time of birth in your patient care report. Remember, some bleeding, usually less than 500 mL, occurs before the placenta delivers and is normal and expected. The following, though, are emergency situations. More than 30 minutes time has elapsed and the placenta still has not delivered. There is more than 500 milliliters of bleeding before delivery of the placenta. There is significant bleeding after the delivery of the placenta, and if one or more of these events occur, transport mother and infant promptly to the hospital. Neonatal assessment and resuscitation. Follow standard precautions and always put on gloves before handling a newborn. A newborn infant will usually begin breathing spontaneously within 15 to 30 seconds after birth, and the heart rate will be 120 beats a minute or higher. If you do not observe these responses, gently tap or flick the soles of the feet or rub the back, and begin resuscitative efforts. Many infants require some form of stimulation that will encourage them to breathe air and begin circulating blood through the lungs, and some of these include positioning of the airway, drying them off, warming them up, suctioning, and tactile stimulation. To maximize the effects of these measures, you should follow some of these following tips. Table 31.2 gives you some resuscitation tips for a newborn who is not breathing. Position the infant on his or her back with the head down and the neck slightly extended. Place a towel or blanket under the infant's shoulders to help maintain position. Suction the mouth and then the nose using a bulb syringe or a suction device with an 8 or 10 French catheter. Suction both sides of the back of the mouth, but avoid deep suctioning of the mouth and throat. Aim blow-by oxygen at the infant's mouth and nose during resuscitation. In addition to drying the infant's head, back, and body vigorously with dry towels, you may rub their back or flick or slap the soles of their feet. Observe the newborn for spontaneous respiration, skin color, and movement of the extremities. Evaluate the heart rate by palpating the pulse at the base of the umbilical cord or at the brachial artery. The heart rate is the most important measure in determining the need for further resuscitation. So, Table 31.3 tells you about heart rates and what we need to do based on changes. If chest compressions are required, give them at a rate of 120 beats a minute using either the enhanced encircling technique or the two-finger technique. You would coordinate your chest compressions in neonatal resuscitation with ventilations at a ratio of 3:1. Any newborn who requires more than routine resuscitation requires transport to a hospital with a Level 3 neonatal intensive care unit. Kalispell Regional Medical Center does have NICU. About 12% of deliveries are complicated by the presence of meconium. If you see meconium in the amniotic fluid or meconium staining and the infant is not breathing adequately, you should continue to vigorously suction the infant immediately after delivery. The APGAR score. The APGAR score is the standard scoring system used to assess the status of a newborn. It assigns a number value of 0, 1, or 2 to 5 areas of activity. The first is appearance. The skin of a light-skinned newborn infant and the mucous membranes of a dark-skinned infant should turn pink. Blue skin all over or blue mucous membranes signal central cyanosis. Pulse. If a stethoscope is unavailable, you can measure pulsations with your fingers in the umbilical cord or the brachial artery. An infant with no pulse requires immediate CPR. Grimace or irritability. Grimacing, crying, or withdrawing in response to stimuli is normal in a newborn and indicates that the newborn infant is doing well. The way to test this is to snap a finger against the sole of the infant's foot. Activity or muscle tone. The degree of muscle tone indicates the oxygenation of the newborn infant's tissues. Normally, the hips and knees are flexed at birth, and to some degree, the infant will resist you straightening them out. A newborn should not be floppy or limp. Respirations. Normally, the newborn's respirations are regular and rapid with a good strong cry. If the respirations are slow, shallow, or labored, or if the infant has a weak cry, the newborn infant may have respiration insufficiency and need assistance with ventilations. Complete absence of respirations or crying is a very serious sign. The total of 5 numbers is the APGAR score, and a perfect score is 10. Calculate the APGAR score at 1 minute after birth and 5 minutes after birth. Table 31.4 gives you APGAR scoring. As you see, area of activity on the left, appearance, pulse, grimace or irritability, activity or muscle tone, and respiration, and 2, 1, and 0 across the top. So when you're looking at appearance, is the infant entirely pink? Is their body pink but hands and feet blue? Or are they blue or pale? You score based on this. Heart rate, respiratory rate are pretty easy to understand. Grimace or irritability, you look at these things. Activity and muscle tone, very quick to do. However, if the infant is in severe distress, defer the APGAR score to resuscitate the newborn. So, quickly calculate the APGAR score to establish a baseline of the newborn status. Suctioning and stimulation should result in an immediate increase in respiratory effort. If they do not, you must begin ventilations with a BVM. If the newborn is breathing well, you should next check the heart rate by feeling the brachial pulse or the pulsations at the base of the umbilical cord. It should be at least 100 beats a minute. If it's not, begin ventilations with a BVM, and then reassess both respiratory effort and heart rate every 30 seconds. Assess skin color. Look for central cyanosis, and if present, administer blow-by oxygen by holding oxygen tubing at high flow close to their face. You should request a second unit as soon as possible if you determine the newborn infant is in any distress and will require resuscitation. In situations in which assisted ventilation is required, you should use a newborn BVN. Make sure you have a good mask-to-face seal and use gentle pressure, making the chest rise with each ventilation. If the infant does not begin breathing on his or her own or does not have an adequate heart rate, continue CPR and rapid transport. And once CPR has been started, do not stop until the infant responds or is pronounced dead by a physician. Complicated delivery emergencies. Breech. The presentation is the position in which an infant is born or the body part that is delivered first. Most infants are born head first, and this is called vertex. Occasionally, the buttocks are delivered first, and this is called a breech. The infant is at great risk for trauma from the delivery, and prolapsed cords are even more common in a breech delivery. Breech deliveries usually take longer, so you will often have time to transport the mom. However, if the buttocks have already passed through the vagina, the delivery process has begun, and you should provide emergency care and call for ALS assistance. If the mother does not deliver within 10 minutes of the buttocks presentation, promptly transport and consult medical control to give you direction. To prepare for a breech delivery is the same as normal childbirth. Position the patient, prepare the OB kit, place yourself and your partner as you would for a normal delivery, and allow the buttocks and legs to deliver spontaneously, supporting them with your hand to prevent rapid expulsion. Let the legs dangle on either side of your arm while you support the trunk and chest as they are delivered. The head is almost always face down and should be allowed to deliver spontaneously, and you should make a V with your gloved hands and position them inside the vagina to keep the walls of the vagina from compressing the infant's airway. On rare occasions, the presenting part of the infant is neither the head or the butt, but a single arm, leg, or foot. This is called the limb presentation. An infant with a limb presentation cannot be successfully delivered in the field. Generally, they need a cesarean delivery, and this is required at the hospital. You must provide rapid, immediate transport. If a limb is protruding, cover it with a sterile towel and never try to push it back in, and never pull on it. Place the patient on their back with their head down and their pelvis elevated. Remember to give the woman high-flow oxygen. Umbilical cord prolapse, where the cord comes out of the vagina before the infant, must be treated in the hospital. The infant's head will compress the cord during birth and cut off circulation to the infant, depriving it of oxygenated blood. You should not attempt to push the cord back in. There is usually time to get the patient to the hospital, and your job is to keep the head of the infant from compressing the cord. You place the woman on a backboard in the Trendelenburg position or in a knee-chest position. Either of these positions is meant to help keep the weight of the infant off of the cord. Carefully insert your sterile gloved hand into the vagina and gently push the infant's head away from the cord. Wrap a sterile towel, moistened with saline, around the exposed cord and give the patient high-flow oxygen and provide rapid transport. Spina Bifida. Spina Bifida is a developmental defect in which a portion of the spinal cord or meninges may protrude outside of the vertebrae and possibly outside of the body. This is easily seen on a newborn's back and usually occurs in the lower third of the back in the lumbar area. Cover the open area of the spinal cord with a sterile moist dressing immediately after birth to help prevent a potentially fatal infection. Maintenance of body temperature is important when applying moist dressings because the moisture can lower the newborn's body temperature. You should have someone hold the newborn against his or her body. Abortion. Passage of the fetus and placenta before 20 weeks is actually referred to as abortion. Abortions may be spontaneous, called a miscarriage, or intentional. Deliberate abortions may be self-induced or planned and performed in a hospital or clinic. The most serious complications of any abortion, whether spontaneous or intentional, are bleeding and infection. Bleeding can result from portions of the fetus or placenta being left inside the uterus, which is called an incomplete abortion, or from injury to the walls of the uterus. Infection can result from such perforation and from the use of non-sterile instruments. If the woman is in shock, treat and transport her promptly and never try to pull tissue out of the vagina. Multiple gestations. Twins occur about 1 in every 80 births, and usually they are diagnosed very early in pregnancy by the use of modern ultrasound techniques. With twins, always be prepared for more than one resuscitation and call for help. Generally, they are smaller than single infants, and delivery is typically not difficult. Consider the possibility of twins anytime the first infant is small or the mother's abdomen remains fairly large after birth. If twins are present, the second one will usually be born within 45 minutes of the first, and after 10 minutes after the first birth, contractions will start again and the birth process repeats itself. Procedure for delivering twins is the same as for single infants. Clamp and cut the cord of the first infant as soon as it has been born and before the second infant is delivered. There may be only one placenta, or there may be two. You should record the time of birth of each twin separately, and remember they may be so small that they look premature, and you need to handle them carefully and keep them warm. Abuse. There is an increased chance of domestic violence and abuse in pregnant women. Some studies have indicated that 15 to 25% of pregnant women are victims of physical or sexual abuse. Abuse during pregnancy increases the chance of miscarriage, premature delivery, and low birth weight. The woman is at risk from bleeding, infection, and uterine rupture. You need to provide a calm professional approach and pay attention to the environment for any signs of abuse. Your attention to detail will be helpful in your documentation. Pregnant patients who are abused are often scared and may not be honest as to how their injuries may have occurred. You should talk to the patient in a private area away from the potential abuser. And the best way for you to care for the fetus is to treat the mother. Substance abuse. More and more, infants are being born to women who are addicted to drugs or alcohol. The effects of the addiction on the fetus include prematurity, low birth weight, severe respiratory distress, and death. Fetal alcohol syndrome describes the condition of infants born to mothers who have abused alcohol. If you are called to handle a delivery of a drug or alcohol-addicted mother, pay special attention to your own safety. Follow standard precautions and wear eye protection, a face mask, and gloves at all times. Clues that you are dealing with an addicted mother may include the presence of drug paraphernalia and empty wine or liquor bottles. Also, statements made by the family or bystanders or by the patient herself. The newborn will probably need immediate resuscitation, and you should assist with the delivery and be prepared to support respiratory effort and administer oxygen during transport. Premature infants. The usual gestational period is 9 calendar months or 40 weeks. A normal single infant will weigh around 7 pounds at birth, and any infant who delivers before 36 weeks or weighs less than 5 pounds at birth is considered premature. A premature infant is smaller and thinner than a full-term infant, and the head is proportionally larger in comparison with the rest of the body. The vernix will be missing on the premature infant, or it will be very minimal, and there will also be less body hair. Premature infants require special care to survive. They often require resuscitative efforts, which should be performed unless it is physically impossible. With such care, infants as small as 1 pound have survived and developed normally. Postpartum pregnancy. Postpartum pregnancy refers to any pregnancy that lasts longer than 42 weeks. This occurs in about 10% of pregnancies, and the patient may or may not know that her pregnancy has lasted more than 42 weeks. The infant can be larger than a typical 40-week infant, sometimes weighing 10 pounds or more, and this condition can lead to problems with mom and baby. It is obviously a more difficult labor and delivery, and there is an increased chance of injury to the fetus. There's also increased chances of a C-section, and the woman is also at risk for perennial tears and infection. Infants have increased risks of meconium aspiration, infection, and being stillborn, and they may not have been able to develop normally because of the restricted size of the uterus. You should be prepared to resuscitate the newborn, as respiratory and neurologic functions may have been affected. Fetal demise. You may find yourself delivering an infant who has died inside the mother's uterus before labor. The onset of labor may be premature, but labor will otherwise progress normally. In most cases, if an intrauterine infection has caused the demise, you may note an extremely foul odor. The delivered infant may have skin blisters, skin sloughing, and a dark discoloration. The head will be soft and perhaps grossly deformed. Do not attempt to resuscitate an obviously dead infant. Delivery without sterile supplies. On the rare occasion, you may have to deliver an infant without sterile OB kits. Even without the OB kit, you should always have eye protection, gloves, and a protective mask with you. Carry out the delivery as if sterile supplies were available, and if possible, use clean sheets and towels that have not been used since they were laundered. As soon as the infant is born, wipe the inside of the mouth with your finger to clear away blood and mucus. You should not cut or tie the umbilical cord. Instead, as soon as the placenta delivers, wrap it in a clean towel or put it in a plastic bag and transport it to the hospital. Always keep the placenta and the infant at the same level, or elevate the placenta slightly if possible, and keep the infant warm. Postpartum complications. Bleeding that exceeds approximately 500 milliliters is considered excessive. Although up to 500 milliliters of blood loss is considered normal, you should continue to massage the uterus after delivery. Check your technique and hand placement if bleeding continues. Excessive bleeding after birth is usually caused by the muscles of the uterus not fully contracting due to delivery of more than one infant, a long labor process that causes the uterus to be too tired to contract, and parts of the placenta still being inside the uterus. Continue massaging the uterus and cover the vagina with a sterile pad, changing the pad as often as possible. Do not discard blood-soaked pads because hospital personnel will use them to estimate blood loss. Save any tissue that also may have passed from the vagina. Place the woman in the shock position. Administer oxygen, monitor vital signs frequently, and transport her immediately. And never hold her legs together in an effort to stop the bleeding. Also, never pack the vagina with gauze pads in an attempt to control bleeding. Postpartum patients are also at an increased risk of an embolism, most commonly a pulmonary embolus. A pulmonary embolus results from a clot that travels through the bloodstream and becomes lodged in the pulmonary circulation. This obstruction will block blood flow to the lungs and is potentially life-threatening. If you deliver a newborn in the field and the mother begins to report sudden difficulty breathing or shortness of breath, consider PE as a possibility. You should also suspect a pulmonary embolus in a patient of childbearing age with respiratory complaints who have recently delivered, especially with a sudden onset of difficulty breathing or altered mentation. Provide supportive care of airway breathing and circulation by providing high-flow oxygen and rapid hospital transport. In summary, inside the uterus, the developing fetus floats in the amniotic sac. The umbilical cord connects the mother and fetus through the placenta. Eventually, contractions of the uterus will propel the neonate through the birth canal. Throughout pregnancy, the body changes to accommodate the fetus. This primary symptom involved with these changes are the respiratory, cardiovascular, and musculoskeletal systems. As a result of enlargement of the uterus, a pregnant patient's respiratory capacity changes with increased respiratory rates and decreasing minute volumes. A pregnant patient's blood volume increases by as much as 50%, and the heart rate increases by 20%. Increasing hormone levels affect the musculoskeletal system by making the joints more loose or less stable. The first stage of labor, dilation, begins with the onset of contractions and ends when the cervix is fully dilated. The second stage of labor, which is expulsion of the fetus, begins when the cervix is fully dilated and ends with the birth of the newborn. And the third stage of labor, delivery of the placenta, begins with the birth of the newborn and ends with delivery of the placenta. Once labor has begun, it cannot be slowed or stopped. However, there is usually time to transport the patient to the hospital during stage 1. During the second stage, you must decide whether to deliver at the scene or transport. During the third stage, once the infant has been born, you will probably not transport the patient until the placenta has delivered. Complications of pregnancy include hypertensive disorders, bleeding, and diabetes. During a trauma call that involves a pregnant woman, you have two patients to consider, the woman and her unborn fetus. Any trauma to the woman will have a direct effect on the fetus condition. Abnormal or complicated deliveries include breech deliveries, limb presentations, and prolapse of the umbilical cord. Quickly transport the patient with a limb presentation or prolapsed cord to the hospital. Only place a finger or hand into the vagina to keep the walls of the vagina from compressing the infant's airway during a breech presentation, or to push the infant's head away from the cord when the cord is prolapsed. Excessive bleeding is a serious emergency. Cover the vagina with a sterile pad, change the pad as often as necessary, and take all used pads to the hospital for examination. Thanks for your attention, and as always, please bring questions regarding lecture to your instructor to discuss in the classroom setting.